Hi, Chad.
Everybody. Hey, I just texted you. For some reason, I clicked the link and I was in a little room all by myself, just staring at myself. I don't know what I did wrong. Everybody, one more minute. Seems like people are piling in quickly. Oh crap, LJ's here. We were going to talk bad about her until she showed up.
That's what my family does.
Well, it was just like home. All right, why don't we go ahead and get started? Looks like we've kind of slowed as far as new additions. So welcome back, everybody. Hope everyone is doing well. Some new news. It's probably not new or surprising to anybody on this call, but we'll go through kind of implications, what the next steps will be, specifically around the age 5 to 11 vaccine approvals. So we'll just kind of dive in with kind of incidents and then tear into the vaccine, and then LJ probably knows far more than I do, so I'll hand it over to her. So as far as the incidents, we continue to see across most of the community that incidence is stable or slightly diminishing. Now, again, it still seems that there are pockets. Concerningly, in some areas, it seems that the pockets are in the school-age children group. So there has been some concern and issue about that, and people that are obviously very eager to get the vaccine into arms of 5 to 11-year-olds as quickly as possible. What we are seeing, is the hospitals are seeing about the same caseload, but the proportion of unvaccinated continues to be on a slight upward trend, at least in the Finger Lakes region when you look at those who are hospitalized. And then it becomes even more disproportionate if you look at ICU and those who are dying. So we're still seeing this largely becoming a wave of the unvaccinated. The other thing that has been a bit of discussion, and actually even Rachel Walensky from the CDC brought it up in an interview, I believe it was yesterday, and it was talked on the command center call for the U of R about this Delta Plus variant. So the Delta Plus variant has a different spike protein configuration, slightly different than even Delta, which does seem to make it more transmissible. It is not clear at this point if it makes it more deadly or more likely to cause severe infection. All the data that we have to this moment suggests that it is still susceptible to the current vaccines that we have being administered. So two issues. Number one, we are seeing it even locally. So Dwight Hardy, who directs the U of R lab, they are now subtyping all positives. The vast majority of positives are Delta, almost exclusively now, it sounds. But they have found some of these Delta plus like, meaning they contain one or more of these Delta plus spike protein mutations that have been identified. So there's a sliding scale. It's not either you're Delta or Delta plus. You have more and more mutations that make you more Delta plus than Delta, but it's in that sphere, so to speak. So all that's a long way of saying, the circulating variant is Delta. If anything, the Delta plus is appearing fairly widely now, which only makes it more transmissible, but it is not clear that that is necessarily more severe than Delta in and of itself, but we know Delta was worse than Alpha Beta. The other subtype variants that continue, Lambda, Mu, really have not seemingly we've had no evidence of them locally that I'm aware of, and they seem to have kind of fallen off the mainstream as far as discussion. So they don't seem to have the same penetration nationally that was feared, that this would become the super variant of that kind of thing. So it really is still a discussion of Delta being the factor. It has been discussed in multiple different venues that there is an anticipation of a fifth wave that will be coming during the winter. Now, are we on wave 5? Are we on wave 27? Are we on wave 2? I think it all depends on how you draw your curve and when you felt like we ever really got out of COVID world, because we've been in it for 20 some months now. So the big key is that there is an anticipation that we likely, even with vaccinating younger children, will see another wave likely to occur over the winter months. So that most people seem to think that's probably going to come somewhere around January, February kind of time frame. I rely on their modeling and expertise far better than my ability to understand it. But all that is a long way of saying the anticipation is that we are entering an endemic phase, not an epidemic phase at this moment, but that there could be another wave that will come in the coming months, almost regardless of how we do with vaccination, because there are still states that are very low in the vaccination rate. Wyoming, Idaho, some of those Midwestern states and Southern states. So not a good time to go off trail skiing in Wyoming and Idaho this year, probably. But if you're by yourself, feel free, knock yourself out, do whatever you'd like to do. So right now, Wyoming is the worst place in the US to be for COVID at the moment, because they have the lowest vaccination rate and some of the highest incidence rate currently. So that's where we stand. Otherwise, locally, we are doing fairly well. Testing remains readily available, but I realize that still means PCR testing for all, and that that still poses an issue with folks. There's a higher volume of folks seeking testing, and that does create backup in the practices in urgent cares, and that remains an issue. But the ability to accommodate that testing remains stable. So now on to the pediatric vaccination. So Tuesday, which was yesterday, God, it feels like every day is 100 years now. The FDA Vaccine and Related Biologics Committee did meet and approved the age 5 to 11 vaccine 17-0 with one abstention. And just for ducks, for conspiracy theorists, the one abstention has some relation to Pfizer, was my understanding. So it's not that they're abstaining because of lack of evidence. If anyone watched and or read the transcript of this, I think the discussion was actually a pretty good one. There were, I will say, opposing viewpoints within the committee, and they really did vet out, the concern. One of the most interesting points that I think was raised was that we would have to reach the nadir of the pandemic, the lowest case rate that we had experienced before there would be any chance that the risk of the vaccine would, and the risk of myocarditis from the vaccine would outweigh the benefit. And right now we are nowhere close to that nadir. And with the winter months coming, the anticipation is that we, may continue to see another spike. So with that discussion, it was the overwhelming feeling that the preponderance of evidence was largely in favor of continuing with recommending the vaccine, and 17-0 recommendation. But I do think it was interesting to note that scientifically and by modeling, we would have to be at our best day for it to even to be a discussion as to whether the safety of the vaccine was outweighed by the benefit. So I think that's fairly reassuring. And, we are nowhere near that at the moment, just to be clear. So what else about the vaccine is of importance? This also came up at the meeting. The dose of the pediatric vaccine for the Pfizer is 1/3 of the adult dose. It is a 10 microgram dose, unlike the 30 microgram dose that many of us received. So it was also brought up in the meeting that it does appear that there may be some dose dependence to the likelihood of developing myocarditis. One of the members brought up that at a 10 microgram dose, they would not anticipate likelihood of seeing myocarditis. And interestingly, if you look at myocarditis in the 16 and over, the 12 to 15, and then in the data we have for the 5 to 11, there is a progressive downward trend in incidence as you get younger for those receiving the vaccine. So granted, the 5 to 11 is in a smaller cohort at this point because it was in the study, but even in the 12 to 15-year-old, the 16 to 18, and the 18 and over, it did look like the incidence was higher for the myocarditis the older that you were. So that's interesting information and bodes well for kids. The one thing that was brought up that I think many of us have kind of talked about was that the incidence of severe infection among children is relatively low. And a couple pieces of information that I thought were interesting. Number one, and I have no verification of this, and this is just reading the transcripts, 1.9 million kids age 5 to 11 have been infected with COVID since the onset of the pandemic. Almost 1 million of those kids have been infected in the last 6 weeks. So if you look at it from that regard, we've done more in 6 weeks than we did in the preceding 20 months. So that I think does raise some concern that this is an evolving epidemic in young children. It is not a relative rarity in children, as has been relayed. Of those 1.9 million, 8,300 have wound up hospitalized, and I might be off on the numbers a little bit. And it's like 100 and some deaths or something like that they've experienced in that 5 to 11 category. So while the incidence of severe disease is extraordinarily low compared to the masses, we are seeing an upward trend in the last 6 weeks of infection among this category. So again, lends itself to saying that the benefit of vaccination is likely far outweighing the risks of vaccination at this point. The final point that I will bring up, just for, not that anybody probably is not aware of this, the Pfizer vaccination series in children, it's a third of the dose. It still is 2 doses, 21 days apart. And by 7 days after the second dose, the efficacy at preventing moderate to severe disease was 90.7%, which put it on par with what we saw in the adult population, even at that reduced dose of administration. So lots of good data to come out of it. So now what happens next? So the FDA at large has to approve, and then the CDC has to approve. The anticipation is that all of that will happen. The CDC has their vaccine and biologics committee meeting on November 2nd and 3rd. It is anticipated the FDA at large will give their approval sometime between now and November 2nd, and then the CDC will likely take this up at the beginning of their group meeting on the 2nd, so that the anticipation, and the White House has rolled out their plan to start administration by the end of the first week of November. So really talking sometime by the end of next week that we could be looking at vaccine getting into hands and getting into arms. So this could start to materialize very quickly over the next 7 to 14 days for sure. The last piece that I will point out for those that saw the information put out, I think it was by the state yesterday, as far as ordering vaccine, you have to order in 300 vial increments. So they're not doing 100 vial increments at this point. So they specifically call out that they recommend that groups that are ordering have the anticipated need and utility for that volume, because they don't have approval for the 100 vial, 100 dose volume at this point. So that's the last piece that I will throw out there. Other than that, I think that we're largely waiting to hear what the rollout and delivery will be. It sounds as if the vaccine is pretty much just waiting for the CDC approval, and they anticipate being able to get that into administration sites within 24 to 48 hours once the CDC says go. So we could be seeing vaccines administered as early as November 3rd, 4th, if everything goes according to plan at this point. So that's everything I know. And now LJ will tell me everything I lied about.
No, that was awesome. I was like, you just like teed the whole thing up there, Chad. So let's stay on the topic of vaccinations and then circle back to testing at the end, if that's okay. We'll keep going with vaccination. So just to echo what you said about when vaccine is likely to be available, I'm sure people are wondering when vaccine will actually make it to their practices. Because I know some of you have already tried to, or have not tried to, have started to anticipate and set up clinics and scheduling for your patients. In asking about this today, it is still not exactly clear what that date specifically will be. So I would just say that we will continue to stay in touch. Certainly Steve Cook being kind of a medical lead for our area and having the connections to the state, not just to the county, is very helpful. Steve has relayed that the term is called being pre-positioned. So we're trying to understand what pre-positioning means. Does pre-positioning mean it's sitting in New York State at a certain date? Does it mean it's sitting in Monroe County at a certain date? Or is it actually, like in Monroe County and out, or in the outlying counties and out to your practices? We will update you as we know that. I think clearly the earliest potential time could be that November 6th that people are looking at as a Saturday for starting vaccination, but I think we need clarity about when the vaccine will actually be available there. So we will update you as soon as we know. If anyone knows anything different, feel free to add. I wanted to thank everyone who responded to our queries and survey questions and calls. At this point, everyone has been at least asked what their vaccination plan is for children for our pediatric and family medicine practices and what their needs might be. There are a few of you out there who have not responded or we've not been able to connect with yet. If you know you're in that company, please reach out to Renee. Renee has been doing a wonderful job being the point person in that. And I just wanted to say, kudos to all of our practices who are definitely planning to engage in vaccination and either have their plans ready or know what their needs are. We're going to reach out to you individually for those of you who have expressed certain either staffing or other needs. And you can expect a contact from us within the next couple of days to be able to work on facilitating support for your teams. Monroe County, and as well as all of the county health departments, or the majority of the county health departments in the Finger Lakes region, really are doing a great job in terms of connecting with practices to support those efforts. And so the majority of you who are in Monroe County have said that you're going to be receiving your vaccine, continuing in that same vein of ordering through and then picking up distribution. My understanding to Marietta Catrone's question in the chat is that you'll be able to do smaller disbursements through the county in the way that you have been, that you're not going to have to get 300 at a time. That would be if you were ordering directly from the state right now. And I just wanted to also let you know what's happening sort of on a community level, because I think it's kind of helpful to know this is different than the adult vaccine process. So as you're very well aware for adults, it was pharmacies, it was large vac sites, state vac sites and pods, and URMC had kind of open scheduling for people who had any kind of connection on my chart. And so this is really different. Everyone is clearly recognizing the importance of the primary care role and trying to make sure that that is supported. If you do need to refer patients elsewhere, if your situation is that way, or if you're wondering where families might access otherwise than your practice, certainly there are select pharmacies that are going to be vaccinating for kids. We've tried, Erica Dobson has tried for our team to do some outreach, and we know that it's not going to be every pharmacy within the pharmacy chains. There will be a few, but they haven't released that information, and I'm sure that's going to be going out fairly soon, just so you're aware. The county and counties, I'll say plural, will have an approach for some centralized vaccination for kids. But I think really done in an equity sort of mindset, for populations that may not have access to a primary care provider or where primary care providers are clearly having difficulty in managing full vaccination for their patients. So certainly there will be some centralized smaller vaccine pods in the city of Rochester, and we anticipate in some of the outlying counties with their county health departments. But none of these are planned to be huge scale operations, much more to be complementary and supportive of the effort in primary care. From a standpoint for the hospital systems, Rochester Regional is working with their own practices in their hospital system to assure that they are vaccinating in their practices. URMC is doing something similar, looking at the primary care network of practices that serve children, as well as Golisano Children's Hospital pediatric practice and Highland Family Medicine. So they will be doing some collective work in that space. We have specifically set this up. So unlike with the adult vaccination, they will not be opening and advertising to people who do not have a primary care provider within the University of Rochester Medical Center system. So that does mean we have a collective responsibility for children who receive specialty care at Golisano Children's, but their primary care, out in the community, making sure that those highest risk kids are definitely getting access to vaccine. If you are having any trouble with that, clearly you would be able to refer patients to some of the centralized testing sites that will be going on within Golisano Children's and URMC, but we're trying to not advertise or pull away. It's too hard for our primary care teams to plan on vaccinating their own patients if all of a sudden a whole bunch just end up showing up at a centralized site there. So just wanted you to be aware that this has been a very thoughtful approach. And I think one that really is trying to adhere to a collaborative, non-competitive, and supportive approach. So the last thing I just want to say on vaccination is that I wanted to call out the team within AHP that's going to be connecting with your practices so you're aware. We really are fortunate to have Kim Povek working within AHP, but who also did a tremendous amount of vaccination with the county, with the equity pods. Kim was doing this and has so much, there she is, has so much knowledge and expertise and just is a great operations person and a wonderful cheerleader around vaccination effort and champion for that. So Kim is leading our internal team, which consists of Renee Sutton and Erica Dobson, Elizabeth Sharp and Kevin Kelly, and has been supported by some of the work of the rest of our broader team. But that's the crew that's going to be working along with me to reach out and support your practices. And so if you do have questions for any of us, don't hesitate. I'd say you'll have your point people for your practice shortly assigned. And so we'll let you know about that. Kim, Renee, anything else you want to add around the vaccination piece right now? Do we cover enough?
No, I think everyone covered it. I guess the only thing I would add was just to remind folks that they really should sign up for that New York State DOH COVID vaccination listserv. Information, Chad's reference that he made about the, limiting the 100 dose order not being available. That's all coming out of those listserv communications. So we are passing those along, and you'll see them on our website. But if you want to get them the moment they're available, sign up for that listserv.
Excellent. Thanks, Renee. And Kim, you're okay? Nothing else on that front? No.
We covered it.
Okay. All right. Fantastic. So shifting gears for a second, I think all the questions, I just looked at the chat and all the questions about vaccination were answered in the chat already. Shifting just back to testing for a moment. So again, COVID testing for symptomatic patients, I just wanted to update everyone that there are increasing efforts to put point of care PCR testing in schools that are happening both within Monroe County and some of the outlying counties. I don't have which schools machines are being placed in yet, but we will pass on that information if you think it's helpful for you to know. But within Monroe County, my understanding is that there's a number of these Acular point of care PCR testing platforms that are being put in schools. Just for clarification, it's becoming like urban legend. I keep getting these messages like, I can't believe the county is using Cepheid and we're using Cepheid. They're not using Cepheid. I just want to say it like again and again. They went with a different system. Actually, we will take credit for that one because we let them know, please don't go with Cepheid, that was what they were going to go with. And that would have been a very interesting competitive struggle for supplies, since most of you have been invested in the Cepheid platform. So we do know that a number of our local schools will have this platform available in the nurse's office. The idea behind this would be that when a student comes down, or staff member for that matter, with a symptom that qualifies them to as a possible COVID symptom, the nurse would be able to do that point of care test there in the office. Any students with systemic symptoms, obviously fever, other things, are going to be sent home because they're not supposed to be in school for that. But for those kids who've had the single sneeze in the classroom, which freaks everyone out and sends that kid packing to the nurse's office, or for the child who has a migraine headache, or for the child who has a stomach ache for a moment, it gives the nurses an opportunity to have a little bit more control over what they would typically do, because they can at least do the test. It is the PCR test. They can observe if their symptoms resolve in 30 minutes. They can send them back to the classroom, right? So there would be a touch more normalcy in terms of that assessment, and yet it would be high quality testing. It doesn't change the workflows for you and your practices. And it has seemed to me in talking with many of you that overwhelming volume of patients has dropped a little bit, as typically can happen, right, with different viruses peaking in our community. I still know you're still seeing a lot of patients who need COVID testing. The county is continuing to still do their drive up point of care testing. And just wanted to mention again that the Golisano Children's centralized site is available for your patients on referral, should you choose to send them. Again, we have left that site as an on referral as opposed to a self-selected site. And the messaging that has gone out has been because not everything is COVID, and because families we don't want to pull patients away from your practices, particularly for some of you who have point of care testing, and the fact that these kids should have some level of assessment. It makes sense that they do. So the changeover that has happened at the Golisano Children's site, which is located in it's a nice setup in one of the labs that had been closed and now reopened for this purpose. Their staff will do the follow through with the family and contact the school with the result. That responsibility is not being put out to the primary care teams. So if anybody, we have not, pushed on this too hard. There's a few practices who have referred their patients and know the referral pathway. If anybody has a question about that, or especially as you're starting to gear up your staff to focus on COVID testing, and if there's another surge of illness patients that are coming up where they have mild symptoms and you want to go ahead and refer, that site will continue to be open and accepting your referrals. And I just wanted to make sure people were aware about that. We'll keep you updated on what happens with the schools. And I saw in the chat that Victor Schools is doing this. I know that Ontario Schools is doing that in that point of care testing. I believe Fairport is piloting it. And Wayne Central Schools have a program with this. Mariette is asking another question. Do the schools need a letter? No, this is the big thing. So only a COVID negative test, PCR test, or NAT test, nucleic acid amplification test result is required for children to return to school. I'm putting on my other hat for a second, the schools reopening task force just sent out a very pointed Q&A to the schools to highlight this factor, because a lot of you have been having reach out from school nurses saying, I need a letter from your practice. They don't need a letter. They really only need the negative test result. So that is also making it a little more streamlined too, where hopefully your practices won't be called in so many times to have to track down the result or provide the letter to the family. Renee, with our messaging today, I'm going to share with you what the FAQ is that went out to the schools so that people can see that and have that, and then lift that to maybe schools in your area. I'm noticing Brockport is still requesting letters. Brockport is not specifically within Monroe County, but hopefully people could forward that information to them and encourage that, because really it's only the test result that's required on a state level. That's the state guidance. And so most counties should be, oh, Brockport is in Monroe County. Oh my gosh. Sorry about that, folks. I should stop talking. I should get more sleep. So Brockport's in Monroe County, so send that information to them. Why was I thinking Brockport was just outside of Monroe County? Anyway, so I think that we're moving forward. It's not, this has been an interesting roller coaster ride. Like, I'd really like to get off. I'm sure the rest of you would like to get off the ride too. But I think that we're doing a good job by our kids. And the last thing I just want to say to all of these teams is, if you thought you really don't need to test kids with mild symptoms, you really do, because we still are seeing a handful of kids coming in with very mild symptoms to these testing sites, and they're positive. So keep in mind, a cold, what looks like a cold or what looks like allergies still can be COVID, and we still need to be thoughtful and diligent in our process. And wahoo, let's get going with COVID vaccination. That's my last thing. Let's do it. Any other questions or comments? Renee, Chad?
No, I'm good. Anybody else have any questions? Really quiet on the Western Front.
14 minutes early, we are out.
Best day ever. All right. So hopefully next time we see and talk to everyone, we'll be knee deep in vaccination of 5 to 11-year-olds. But until that time, if anything exciting changes or comes up, we will certainly let you know. But I'd say all eyes are now waiting to see what happens on or around November 2nd is the next important date, it seems. So until then, have a lovely rest of the week, and we will talk to you guys next week. Take care, everybody.